Dr. Eugene, it's 3 p.m. Should we start now?
Okay, Afiq, sure. Prof. Laila and Dr. Tivia, can we start now?
Yes. Tivia,
Great.
you can speak.
Yes.
Okay. Great. So good evening, everyone. Thank you to everyone in attendance for attending today. We are currently in our third week for the month of endocrinology. My name is Eugene Koh. I'm a physician currently in hospital Taiping. It's a great pleasure to welcome everyone today. With us today, we have got Prof. Dr. Nur Laila Mustafa, who is our chairperson, and also Dr. Tivia Sunarajan, who is our speaker today, with the topic titled Approach to Panhypopituitarism. Prof. Nur Laila, our chairperson, graduated from UKM in the year 1995 and subsequently obtained her master's in internal medicine from the same university in 2006. And she went on to actually pursue a doctorate thesis in the field of diabetes in University of Cardiff in Wales. As of now, she's currently the professor of medicine and also a senior consultant endocrinologist in hospital UKM. Her main areas of interest include the field of diabetes, reproductive medicine, and also obesity. Without further ado, Prof. Laila, the floor is yours.
All right. Thank you, Eugene. Thank you. Sorry. Thank you, Eugene. Now we'll start the webinar on hypopituitarism. Let me introduce Dr. Tivia. Dr. Tivia is a resident consultant physician and endocrinologist at Pantai Hospital, Ipoh. She graduated from IMU and then further continue her career as a general physician, and later on she joined the endocrinology fraternity in the year 2021. Now, I've known Dr. Tivia for quite some time. She has a strong foundation in medicine as well as endocrinology. And from my encounter with her, she is a very dedicated clinician. What Dr. Tivia is going to do today is that she will share with you cases related to pituitary problems and then guide you along the way how you manage the hormonal deficiency as well as on the replacement therapy. So Dr. Tivia, the platform is yours.
Thank you, Prof. Dr. Nur Laila, for the lovely introduction. It's my pleasure to be part of the Endocrine series webinar organized by the College of Physicians Malaysia. Let me just share my screen. Okay, is everyone able to view my slides?
Yes, Ken, very clear.
Thank you. Okay, so I will be covering a little bit of introduction to the pituitary gland today. What is hypopituitarism? And 4 case studies to illustrate how we replace hormones in pituitary disease. Okay, so as we all know, the pituitary gland, it's a very tiny gland. However, it's the powerhouse which supplies hormones and ensures that our functions in terms of hormones go well in the human body. So basically, we have the anterior lobe of the pituitary gland. We have the posterior lobe as well as an intermediate lobe called the pars intermedialis. So now, the anterior pituitary gland is controlled directly by the central nervous system as well as indirect control to release of regulatory hormones. Now, these regulatory hormones, we have the ACTH, TSH, growth hormone, prolactin, follicular stimulating hormone, luteinizing hormone, and these hormones trigger the other organs to actually release. For example, your ACTH stimulates your adrenal medulla and your gland to produce epinephrine or epinephrine. Your TSH stimulates your thyroid gland to produce T3 and T4. Your growth hormone stimulates the liver to actually produce IGF-1, which acts on bone, muscles, and other tissues. Prolactin stimulates the mammary glands for milk production. FSH and LH stimulates the reproductive organs and your estrogen, testosterone, and progesterone release. And then you have your pars intermedialis, which produces the melanocyte-stimulating hormone. However, the function of this hormone is pretty uncertain in healthy adults for now, still being studied extensively, has some role in terms of obesity modulation as well. And we have the posterior lobe of pituitary gland, which produces ADH, which acts on the kidneys in terms of concentrating ability of urine. And we have oxytocin that works in the uterine glands and in males in the prostate. So this is an overview of the pituitary gland. So now when we talk about hypopituitarism, it essentially means diminished or absent secretion of one or more pituitary hormones. Now, it's a very wide spectrum of diseases depending on which hormones that are deficient, how bad is the hypofunction, and the age. Are they presenting at a very young age? Because at a very young age, you can present with short stature, whereas in an adult, growth hormone deficiency, and you won't see much of a short stature issue at an adult age. So the spectrum can range from one hormone deficiency to two or more hormones. And the term panhypopituitarism basically is coined when you have posterior pituitary dysfunction as well as anterior pituitary dysfunction. Now, what are the common clinical presentations that we see in our practice? So you may see patients presenting with cortisol deficiency and manifesting as hypoglycemia, vomiting, malaise, and postural drop in blood pressure. Patients who have hypothyroidism may have fatigue, constipation, cold intolerance, and bradycardia. This is not something new to us, but just to refresh our memories about this. Patients who have deficiencies of sex steroids will have issues with libido, erection, delayed puberty, amenorrhea in males and females. And when you have growth hormone deficiency, if you're very young, you have stunting or short stature. And when you're older, growth hormone deficiency can cause a lot of other problems such as lethargy, muscle mass issues. You have metabolic problems coming into the picture such as diabetes, hypertension, etc. And when you have ADH deficiency, essentially you have diabetes insipidus causing hypernatremia, excessive urination, and dehydration. Now, what are the causes of hypopituitarism? Essentially, anything that affects the pituitary function can cause hypopituitarism. It may be an invasive or large tumor. It could be blood supply issues causing infarction in the case of, for example, Sheehan syndrome, where you have lots of blood loss during delivery. Postpartum, you have necrosis of the pituitary. You may also have apoplexy, which means hemorrhage and hemorrhagic infarction of the pituitary tumor itself. You could have infiltrative causes such as sarcoidosis, hemochromatosis, not very common, but we do see patients of this sort as well. Any sort of head injury. So you have an MVA, you have a traumatic brain injury, you can have transient issues with your pituitary function. Immunologic causes such as autoimmune diseases, infectious diseases such as tuberculosis, not uncommon though. And you have isolated syndromes as well as chronic systemic diseases such as renal failure, etc. Now, another small thing to note here is that increasingly, I think over the last few years, we are seeing more and more immune checkpoint inhibitor induced hypophysitis, which basically means inflammation of the hypophysis or the pituitary from usage of these immune checkpoint inhibitors in oncological practice for cancer treatment as well. Now, let me go and let me bring you all through the first case for today. This is Madam CF. She's a 55-year-old female, postmenopausal, underlying history of right breast ductal carcinoma stage 1 diagnosed in 2017, mastectomy done, axillary clearance as well. She didn't have any chemo or radiotherapy done and no evidence of metastasis to date. She has been on oral tamoxifen for the past 2 years and she's been doing yearly mammograms with no evidence of recurrence and purely under oncology. Her issue was she presented with polyuria for the past 3 months, worsening over the last 2 weeks. Up to every hour, she would go to the toilet 2 or 3 times. Associated with excessive thirst, up to 8 liters of urination in a day. No other medications on board. She had some giddiness during presentation, denies any headache or visual loss. Clinically, she has a right mastectomy scar, no new lumps, no lymphadenopathy. Hydration is fair because she has been actually compensating by drinking as much as she has been losing. Her weight is 53 kilos and she has a postural drop in her blood pressure. Now let's look at the hormonal profiles that we have taken for her. So as you can see here, staring right at you, the urine osmol is actually low. It's 94 milliosmoles per kilo with an increased or elevated serum osmolarity. The urine sodium is 45 and you have a low urine specific gravity of 1.002. Now, what does this tell you? So when a patient comes to you with polyuria, I'll go through how you actually approach a patient with polyuria. But the first thing that will come to your mind here is the possibility of diabetes insipidus. Apart from that, she had a low T4 and a low TSH. So in primary hypothyroidism, your TSH will be elevated. For someone who has a T4 that is low, by right, your TSH should be even higher than your reference range. But in this case, she has a low T4 and TSH, which makes us suspect secondary hypothyroidism in this picture. A1C is 5.2%. Now, why did we do a HbA1c and a fasting sugar? When someone has polyuria, diabetes is something that you need to exclude first, because that is a common cause of polyuria as well. Her sodiums were elevated at 149, and she had a random cortisol that was low, less than 14 nanomoles per liter, with a low ACTH as well. Her prolactin levels were mildly elevated at 735 milli-IU per liter, and she had low FSH-LH as well. So in this patient, she likely has diabetes insipidus, secondary hypothyroidism, hypocortisolism, and hypogonadism. Now, let's try to put the whole thing together and tie it in. Now, this is the summary again. And why did I say that she has central hypogonadism? She is postmenopausal. Ideally, you would expect the FSH and LH to be in a double digit or even higher range because she is postmenopausal, but we see a low FSH and LH in this picture. Now, this is her actual pituitary MRI. This is a case I saw many years ago in Hospital Kuala Lumpur, and this is the actual image of the MRI, and it shows a thickened stalk. I hope you can see the arrow that I'm demonstrating here. There's a thickened stalk, very enhancing thickened stalk, and a nodule on the left pituitary region. Here, I'm just showing you how a normal pituitary would look like on the right-hand side. See, it's a very thin, tapering structure, very clean, very clear stalk versus a thickened stalk. And you can see that the stalk is also deviated to the left over here, and there's a nodule, the left pituitary over here as well. So this was her MRI. This is another patient's MRI that I found online, just to show you all that this is another patient who actually presented with a similar complaints of polyuria, polydipsia with underlying breast carcinoma. And as you can see, the stalk looks like a button here compared to the normal pituitary stalk on the right-hand side here. This is just to show you all how a pituitary MRI and a stalk looks like, a normal versus an abnormal stalk. Here, it's actually enhancing diffusely post-gadolinium as well. Now, when you're trying to approach polyuria, first of all, ask the patient to objectively demonstrate that they have polyuria. Ask the patient to record how much is their intake, how much is their output. If the patient is in the ward, get them to monitor the urine output. And you confirm polyuria by measuring the urine output, you'd have more than 50 cc per kilo per hour or more than 3 liters per day. Secondly, ensure the patient doesn't have diabetes. Check the sodium levels and also the plasma and urine osmolalities. These are the first few things that you would do. You'd also look at other electrolytes such as calcium and potassium, etc., because hypokalemia can also cause polyuria. So we try to exclude all these other causes. Also look at what drugs the patient is on before we say that it's possibly diabetes insipidus. Secondly, if the patient has a urine osmolality of more than 600 milliosmoles per kilo, effectively you have ruled out diabetes insipidus. However, if the patient has a high sodium of more than 146 with a high osmolality more than 300 and a low urine osmolarity of less than 300, diabetes insipidus is invariably diagnosed already. But if you're uncertain, in cases such as normal sodium, plasma osmolality is borderline, you're not too sure what's happening with the patient, then you would probably ask for help. Or if you have an endocrinologist at your center, discuss and probably arrange for a water deprivation test to actually establish a diagnosis. Again, remember that we have patients who love to drink water and you have other disorders of primary polydipsia. So this is something that you need to keep at the back of your mind as well when you're assessing someone with polyuria. Again, what would we do? Usually we'll get a whole hormonal profile. We'll subject the patient to a water deprivation test, provided the patient is stable. And I also go through how we actually go about doing it shortly. Okay, so all right. So water deprivation test basically is the investigation of choice for diabetes insipidus. A little bit cumbersome, but basically the principle is to deprive the patient of fluids to allow the osmolality of the serum to rise and see whether the urine is able to concentrate or not. Patients usually fasted overnight and they may or may not be allowed fluids overnight, but on an hourly basis, we do the urine and serum osmolality measurements, including the patient's weight and how much urine the patient is pouring out. Now, the endpoints to stop the test is when you reach a serum osmol of more than 300 milliosmol or you have a more than 5% loss of body weight. And at that point, if your urine osmol is more than 600 again, DI is excluded. If the urine osmol is less than 200, diabetes insipidus is diagnosed. And if it's in between, then you would probably see what else we can do to test it. But if you have diabetes insipidus diagnosed, you could actually give vasopressin at that point in time and see whether the patient is able to concentrate the urine to more than 600, which would mean that it's a pituitary cause of diabetes insipidus versus a nephrogenic cause. So this is, don't worry, I'll share the slides. This is the cutoffs. Again, this protocol has different variations and different cutoffs, but generally, these are the cutoffs for the urine and serum osmolality to differentiate between central and nephrogenic DI. What are the other tests in diabetes insipidus? We also have a little bit more expensive test called the CoPeptin test. CoPeptin is basically the C-terminal peptide of the prohormone for the AVP. It is produced by the posterior pituitary on an equimolar basis with AVP. So measuring AVP in the serum is not very easy because the levels can fluctuate vastly. So we use the CoPeptin because it's more stable, easily measurable, and we have certain cutoffs for it. And we also do tests such as hypertonic saline stimulation at times to actually look at the CoPeptin level and diagnose cranial diabetes insipidus. This is something that you just would want to know as well. Now, our patient earlier, why is the prolactin elevated at 700 plus when the cutoff was about 600? Okay, so as we all know, the prolactin is quite special in the sense that it works in a negative feedback mechanism by dopamine. So when there's any sort of supracellular or cellular lesions extending to disturb or interrupt the stalk, it can lead to hyperprolactinemia and consequent galactorrhea. So because it disrupts the whole dopamine pathway and secretion from the hypothalamus to the pituitary. So any sort of thing that disrupts the stalk can cause a mild increase in the prolactin levels, but generally it's rarely higher than 250 nanograms per ml. So now our patient, she was put on subcut desmopressin 2 to 4 mics intermittently in the ward. This is just a summary of what happened. And she had multiple episodes of pouring and we adjusted it. And then she was converted to regular oral minerin 0.1 milligrams twice a day. She was started on hydrocortisone replacement and was tapered to 10 BD upon discharge. And she was started on thyroxine 50 mics on morning. Now, what are the preparations of desmopressin do we have in our setting? We have the oral desmopressin tablets that come in 0.1 and 0.2 milligrams. You may even choose to give 0.05 milligrams. And the equivalent are the minerin melt by Ferring. This comes in 60 mic and 120 mic dosages. And if you actually want to give a subcutaneous dose, you could give subcutaneous desmopressin acetate, which comes in 4 mics per ml. You could give 2 or 4 mics generally. Now, what are the side effects of desmopressin? Just remember anything that anything that works on the ADH hormone can cause hyponatremia because you're essentially giving this to bring down the sodium and help to concentrate the urine. So hyponatremia is something that we worry about. So in terms of hormone replacement, every patient is different. You may see patients who have 0.05 milligrams or 0.1 milligrams of minerin, and others may have up to 0.4 and 0.6 milligrams of minerin. So all this is individualized and it be based on fluid intake and sodium levels. So usually we will adjust this based on their fluid intake and sodium levels in the ward and discharge the patients with that. And we'll educate all the patients about the risk of overdosing. And it would be good if they can keep a diary to monitor what are their inputs and outputs like for the first few weeks after being started on minerin. We usually give the lowest dose that allows enough rest at night and minimal disruption of individual daytime activities. So we time it because it tells us that, okay, my polyuria is very bad in the morning. I need to go to work, and you probably can time it around that time, just a couple of hours or two before that to actually help them in their daytime activities. Okay, so hyponatremia is something that you want to look out for in these patients. So whenever you see patients coming for follow-up who are on minerin, you probably not do a plasma and serum osmolarity, urine and serum osmolarity, but you probably get a sodium level to see whether they're adequately replaced or not. Now, one thing to take note is that adrenal insufficiency can mask diabetes insipidus by impairing the free water clearance. So if you have a patient that you suspect, okay, they come in with visual deficit, and on the MRI you have a pituitary adenoma and it is large, and you know that the patient is has hypoadrenalism, you're going to start steroid replacement. Be aware that the patient can start pouring as well, because this would unmask their cranial diabetes insipidus. So how do you manage this? Usually we manage this simultaneously by giving the hormone replacement. Now, a little bit of pearls in terms of hydrocortisone replacement. What are the timings like? So frequently we see patients with on hydrocortisone, and they tell me like, oh yeah, doctor, I take it in the morning and at night. 10 o'clock in the morning and maybe at 6 o'clock or 10 o'clock at night. Doctor told me it's BD dose twice a day. Okay, so this is very common. And then they tell us that they can't sleep at night, they're hypo at night, can't go to bed, etc. So the timing is usually upon waking up. The first thing you do is taking it in the morning when you wake up. And the second dose is probably around 12 to 2 o'clock in the afternoon. We don't usually ask them to take towards the night time, because why is it such? It's because our cortisol release in the body follows a circadian rhythm, and the peaks, there are two peaks. The first peak is around 4 to say 8 or 9 o'clock in the morning, and the second peak is in the afternoon. So we try to mimic the normal circadian rhythm. That's why we give it upon waking up and in the noon. Some patients don't do very well with speedy dosing morning and afternoon, so sometimes we give them an additional dose, say around 5 o'clock or 4 o'clock. Say maybe 10 milligrams in the morning, 5 and 5 at afternoon, and around 4 o'clock. So again, it depends on the patient's symptoms as well. But the usual dose is around 15 to 20 milligrams. We try to adjust it so that the patients do not have adverse effects of too much of steroids as well. So the patient should be seen clinically in terms of their blood pressure, their diabetes, their weight gain, etc., and adjust the dose accordingly. Always remind your patient that if they fall ill, if they're unwell, stress dosing and how much do they increase their dose to is something that you need to talk about and discuss with them early on when you start them on hydrocortisone. And then they also need to know what they're having. And when they go to the hospital, they need to tell the doctors that they are on this medication and all this. They need to probably have an emergency card, and maybe in the overseas, they have a bracelet and necklace regarding their adrenal insufficiency as well. Now, what are the sick day rules in terms of hydrocortisone? Very simple: double the routine oral glucocorticoid dose when the patient has a fever or illness, or when they require antibiotics for a simple infection or before a small outpatient procedure. Subsequently, you can go back to their normal dose. If they're severely ill, persistently vomiting, or they have a surgical intervention due, then you would probably inject a glucocorticoid preparation, IM or IV, preemptively for this kind of patients. Something to take note here, that if you're going for surgery, generally a little bit different. We give hydrocortisone 100 milligrams IV on induction for anesthesia, and then followed by about maybe 50 QID for a couple of days, and then we'll cut it down and taper it down from 20 TDS, 20 BD, and then back to their old doses when they recover. Now, in terms of secondary adrenal insufficiency, a few things to take note. The first line test to diagnose it is an 8 to 9 a.m. serum cortisol level, not a random cortisol level, okay? And if the cortisol level is less than 82 nanomoles per liter, it is indicative of adrenal insufficiency. If it's more than 410, it is unlikely. If it's in between, then you will need further stimulation tests to actually confirm the diagnosis. What is the gold standard to assess ACTH and cortisol reserve? It is the insulin tolerance test. It's not the synectin test, but I'll tell you why. Okay, so what is the principle behind this? You administer insulin depending on the patient's insulin resistance. Some of them are diabetic, then we may give higher doses of insulin. So generally, a rough guide is about 0.05 to 0.15 units per kg IV. And we collect samples at baseline, 30, 60, 90, and 120 minutes for cortisol, glucose, and we also do an ACTH. So now, we are trying to induce hypoglycemia to a level of less than 2.2 to elicit a cortisol response in these patients. That's basically the principle of it. But you need to be careful because this test is a little bit risky. Having hypoglycemia in a patient with epilepsy or stroke or coronary heart disease can be dangerous. So there are a few caveats. If you have coronary heart disease, CVA, or history of epilepsy, be very careful and maybe discuss with the patient regarding other forms of testing as well. And this needs to be done under endocrinologist supervision. This is an example of a test that I did when I was training. So basically, you can see here, we give insulin, we induce hypoglycemia at 2.1. We monitor the patient closely with dextrose and everything on board, standby. Yeah? And then we look at the peak cortisol response. So adequate cortisol response is defined as a rise to above 500 nanomoles per liter. Again, these cutoffs vary from 450 to 500 to 550. And the peak serum, again, just to let you all know that this test is also used to diagnose growth hormone deficiency. So we also do a growth hormone testing at the same time. This test was done for someone who had a post-pituitary surgery for non-functioning pituitary adenoma to see if we can stop the hydrocortisone for this patient. So as you can see here, this patient is growth hormone deficient as well because the peak serum growth hormone never reached more than 5 mics per liter at any time point during the hypoglycemic phase. So this test can be used in a nutshell to diagnose growth hormone deficiency as well as hypocortisolism. What about synectin test? Okay, yes, we can use the synectin test. It is an indirect assessment of the HPA axis in cases of suspected secondary hypoadrenalism. However, if you have a patient that is post-surgery, that means they had a tumor, you remove the tumor, and you're going to assess whether their axis is functioning or not, your gold standard will still be the ITT or the insulin tolerance test. When you're doing a synectin test for patients with the possible secondary hypopituitarism or hypoadrenalism, you're assuming that the chronic ACTH deficiency has caused adrenal atrophy, and there'll be a consequent impaired response to stimulation by your synectin. And don't forget that for the ITT and for the synectin test, you need to withhold the last hydrocortisone doses. We normally tell them to withhold that morning and the PM before. So 2 doses you omit and then come for the testing on that particular day. How is it done? Essentially, we insert a granula at 9 o'clock or 8 o'clock in the morning. We measure cortisol levels. It can be done actually any time of the day, by the way, and doesn't need to be a fasted sample. We inject 250 mics of ACTH. This is giving a supra-physiological dose of ACTH and looking at the blood samples for cortisol after 30 and 60 minutes. And if you hit a peak of, say, 450 to 500 or 550, it is actually a normal test. What if your patient is non-compliant to the hydrocortisone? Some of them, they say, Doktor, pagi saya makan ubat, then tengah hari saya lupa. Okay, or patients want to fast, or it's not available, then you can actually choose prednisolone instead. This is just a guide for you all to actually convert hydrocortisone to prednisolone. But generally, if you're using a 15 milligram hydrocortisone, the equivalent dose of pred would be around 3.75 milligrams. We don't recommend dexamethasone. Yeah, you can actually choose prednisolone instead. This is just to show you all the approximate equivalent doses. So now this patient, we discussed with her, the neurosurgeons came into the picture about a biopsy. She didn't want, and it wasn't a very good idea to do a biopsy for her as well. It made things worse. So she was planned for stereotactic radiotherapy. She was given minirin, adjusted again, and the sodium levels were 139 at that time. But we did a TFT for her 3 months later, and this is the result. Now, if you are the clinician seeing this patient, what would you do and how would you manage her? Her T4 was 8.1, if I'm not mistaken, earlier, 3 months ago, and we gave her a 50 mic thyroxine. So what are the things that you would want to know? Is she taking the medicine properly? Is she taking it with any other medications or in relation to food? Because as we all know, it's supposed to be taken on an empty stomach because absorption is best in an acidic environment, and any sort of concomitant medications such as proton pump inhibitors, your calcium and any other medications can actually interfere, including iron tablets. And also ask the patient if they have any symptoms to suggest gastritis or malabsorption that needs further workup. So these are the few things that you would want to ask a patient before you increase the dose to 75 or 100 mics. Now, a few things about thyroid hormone replacement. The T4 targets is in the mid to upper half of the reference range. So this is the upper half. You'd keep it somewhere in between here to a bit of a higher limit of the upper reference range. Don't use TSH as a guide for replacement adequacy. Generally, we use a dose of 1.6 micrograms per kg per day, and you adjust it. Okay, an 80-year-old patient is not the same as a 24-year-old patient. They may have ischemic heart disease and all that on board. So you'd probably go slower on a patient who has ischemic heart disease or an elderly patient. whereas you probably will go full replacement doses someone who is younger. So it depends, and you can use the free T4 levels a month or two later to actually adjust. And then don't interpret undetectable TSH levels as a sign of over-treatment. Okay, because if you have a patient with primary hypothyroidism, say you're giving the patient 125 mics, and the TSH is suppressed, it was initially say 40, and now it is suppressed, then you would think of, oh, maybe I'm over-treating this patient, I need to cut down the dose. But in a secondary hypothyroidism patient, don't look at the TSH levels as a sign of over-treatment, especially if the initial TSH was measurable. Okay, and it's a good practice to ask them to fast and come for the test, because sometimes when they take the thyroxine, just before doing the T4 test, it may show a slightly higher value than what it is actually. Okay, now let's go to case number 2. I think I'm going quite slow. Sorry, half an hour. Okay, so case number 2 is a 28-year-old Chinese male. He's got isolated hypogonadism diagnosed at a young age of 16 when he failed to attain puberty. MRIs were normal, and currently he's on 250 milligrams per month of IM testosterone enanthate. Testosterone levels are 4, LH, FSH on the low end, and his AM cortisol, thyroid function, prolactins are normal range. So this is a hypogonadism. What would you like to know? You would actually ask for signs of testosterone deficiency, lethargy, low libido. He doesn't have any early morning erections. Clinically, this is not the patient, by the way, but clinically, he has a male voice, sparse axillary and pubic hair, and his tennis 3. Testis bilatery, 5 males. What are the things you want to know? So I think these kind of patients you always see. You see a patient with non-functioning pituitary adenoma, then you see the testosterone level, it could be on the low end. Or you see a new case coming in with a testosterone that is low. He may or may not be on injections, but if he's on testosterone injections, compliance is something that you want to ask. Number 2, when was the level taken in relation to the injection? For example, if the injection was given today, was the level taken 2 weeks later, 1 week later, or at the end, just before the next jab? This is very important. Number 3, did the patient fast for the test? Why is that important? Because glucose or food can suppress the testosterone levels. Number 4, is the patient on any other medications, herbal supplements, over-the-counters, etc.? Now, ensure absence of illness. Don't go and take a testosterone level when the patient is very ill, has COVID, etc. And take it usually before 10 o'clock in the morning after an overnight fast. So fasting is important, morning is important, because testosterone also has a circadian rhythm. Now, testosterone deficiency doesn't just affect sexual function, but it affects it causes anemia, it causes reduced fat mass, and also it has an effect on bone mineral density and sense of well-being, muscle mass, and strength. If you have one low testosterone value, always repeat it with the same assay, especially if it is borderline low. Why? Okay, now, about 2% of our circulating testosterone is free or unbound, but 44% is bound to this component called sex hormone binding globulin. And the sex hormone binding globulin has a lot of conditions that increase and decrease it. The commonest that we see is obesity, metabolic syndrome, type 2 diabetes mellitus. Okay, this is very, very common. In these patients, you have a decrease in SHBG, which affects your testosterone levels. So if you see patients like this who have a testosterone level in the border low or in the lower end of normal, look at the conditions and that alter the SHBG, take a SHBG level and then correct it to get a free testosterone level. You could do it by serum testing, or you could use calculators that are online to actually estimate the free testosterone concentrations as well. Generally, you aim at achieving testosterone concentrations in the mid-normal range during treatment with any of the approved formulations. Now, what are the contraindications to testosterone therapy? Breast cancer, prostate cancer, a PSA of more than 4 nanograms per mil, and hematocrit being more than 54%. If it's more than 50%, it's a relative contraindication. Again, ask your patient if they desire fertility, because testosterone suppresses some spermatogenesis. If they have very bad lower urinary tract symptoms, it's a relative contraindication. Need to discuss with the patient. And if they have obstructive sleep apnea or CCF, congestive cardiac failure, these are relative contraindications as well. Now, what are the preparations that we have? In the government side, we have the enanthate, which is about 200 or 250 milligrams, every 2 to 3 weeks or even monthly. It is inexpensive, quite flexible, but the problem with it is that it can be associated with fluctuations in symptoms. It's not very stable. So basically, after a single injection, it rises to a supraphysiological range. So it goes up really high, and then it declines to a hypogonadal range towards the end of the next jab. We also have transdermal gel. In Malaysia, we have the Androgel, which comes in 50 and 100 milligrams, 1%. And this one provides flexibility of dosing, no injection needed, less erythrocytosis than the injectable forms. But the thing is, there's a potential of transfer to a female partner. Skin irritation issues are also there as well. Number 3, if you have patients that are not doing too well on the inantate preparation and they want a more stable testosterone level, it means towards the end of the jab, they're having symptoms of testosterone deficiency, etc., then you may choose an injectable long-acting undecanoate in oil. We have the Nebido, which is about 1,000 milligrams. Again, they have the 750 and 1,000. Usually give a loading dose, IM, followed by at 4 weeks another dose, and then every 10 to 12 weekly. So generally, this Nebido is accepted. I mean, the acceptance is quite good because it's infrequent and you have to jab only once in every 2 or 3 months. So when do you measure testosterone levels? If you're taking the inantate, you measure it midway between injections. So if you're taking it monthly, 2 weeks after the jab, you would do a testosterone level, and you can adjust the dose of frequency. So your dose may be adjusted from 250 to 200 mics or 150 mics, or you may actually choose to bring forward. That means if it's on a monthly basis, you can bring it to 3 weekly basis. The gel, you assess it 2 to 8 hours following the gel application after the patient has been on treatment for at least a week. Again, the target is mid-normal range. When you're on an injectable long-acting undecanoate, you measure it at the end of the dosing interval just before the next jab to achieve a low mid-range level of testosterone. How do you monitor patients? You look at testosterone levels, 3 to 6 monthly. You look at the hematocrit. This is why we order a full blood count, if you all are wondering why. And we also do a PSA level, especially if the patient is more than 40 years old. Generally, prostate screening is done for patients that are more than 40, and we do a PSA with a digital rectal examination. And you may need a urologist if the PSA goes up by more than 1.4. How about in females? These are just the principles. You usually give estrogen plus progesterone preparations for those that have an intact uterus, because you don't want to have endometrial hyperplasia. But for those who do not have a uterus, you would give unopposed estrogens, and you replace until the mean age of natural menopause, which is about 45 years old. This is something that we commonly give our patients who have secondary hypogonadism, females. We have the white pills here that are given for about 11 days. That's just estradiol 2 milligrams. And then on the 12th day onwards until 21 days, they are given a combination of progestogen and estradiol. And then they are asked to stop, and they have a withdrawal bleeding for 7 days, and the cycle starts back again. So this is a common preparation. I think you all should know about it. Now, we're coming to the last case. It's 340. Okay, so this girl is 15 years old. I decided to take this case up because I wanted to cover all the hormones. So this is a case of growth hormone deficiency. This is a 15-year-old girl, short stature, delayed puberty. Parents noticed only now that she was shorter than her peers. Birth weight 3.1 kilos, attained all her usual milestones, not much of issues, no allergies, immunizations are up to date, no history of head trauma, and she has not attained her menarche yet. So when you say short stature, what's the definition? It is height below the 3rd percentile or less than 2 standard deviations below the median height for age and sex according to the normal population. So her mother is at 150.9 centimeters, menarche at the age of 12, father is 168.5 cm, and this is the mid-parental height. So this is the formulation to actually calculate the mid-parental height, and the target should be plus minus 2 standard deviation or 10 centimeter away. So the patient's height is clearly faltering at 132.5 centimeter. Her 2 older sisters, aged 18 and 20 years old, both had menarche at the age of 12, and they are way taller than the patient. Usually we use growth charts. You can obtain this online, or even in our government hospitals, we always have this chart. So this actually gives us an idea of how the patient is doing in terms of height and weight. So if your child is at the 90th percentile, this implies that they are taller than 90% of the children of the same age and sex, and vice versa if it's lower. Similarly for weight as well. So always get a growth chart and plot if you're thinking of possibility of short stature. So this girl is 132.5 centimeters. She falls below the first centile in terms of height. At 29.5 kilos, she also falls below the first centile for weight. Her BMI is 16.9. She has dry skin, no visual deficit, and she is at tennis 1. And sorry, she also has she has no postural drop in blood pressure. Now, this is for patients, this is for students or doctors sitting for the MRCP examination. I myself had a patient with hypopituitarism as a clinical case for PACES. So watch out for, it can be very subtle. It can involve different kinds of target hormone. This is a general clinical examination. For hypothyroidism, look out for a soft or small thyroid gland, dry and coarse skin, thinning of hair, alopecia, your eyebrows, thinning of eyebrows, delayed reflexes, cold skin with loss of sweating, and non-pitting type of edema. Always check the PP sitting and standing or lying and standing. Hypogonadism, look at the tenor staging for the patient, examine the testes, and also axillary hair and pubic hair in women, and breast examination as well. And always complete your examination with a neurological and ophthalmic evaluation as well to ensure that there's no loss of visual acuity or bitemporal hemianopia. So this is our patient just now. This is her chart. She falls below the first centile for weight and height. Now, this is a little bit about tenor staging. So generally, when you going into or entering puberty, you should be at stage 2, where you have breast bud appearance and enlargement of areola. In a male, if your volume of your testis is less than 4 mils, it means that you are at a pre-pubertal stage. So your testis volume is less than 3 at a tenor stage 2, then you enter into puberty into the stage 2 and 3 over here with further testicular enlargement. This just gives us a guide. I will share the slides later with you all as well. Okay, so now this is an oculometer. This is known as the jewelry for the endocrinologists. Okay, this is an oculometer, and basically we use this to actually ascertain the size or volume of the testis, actually, not size, okay? Volume of the testis. And if a testicular volume is more than 4 mils, it signifies pubertal development. And a normal adult testicular volume should be more than 15 mils. Again, here you can see that at stage 2, you're just entering into puberty. Your testicular volume is about 4 mils, and then it becomes, it actually increases as tennis, you go into tennis 3 and tennis 4 later on. So now, in this patient, what are your differential diagnoses? Would you entertain a possibility of constitutional delay of growth and puberty? She's 15 years old, something to think about. Turner syndrome. Turner syndrome is where you have premature ovarian failure. Let's just look at the investigations after this. Or could it be some sort of chronic condition? This is something that we've already ruled out. She doesn't look like she has any malabsorption, etc. Or could it just be hypopituitarism? So these are the labs of the patient. She has a low LH, FSH, and estradiol, which essentially tells us that she is hypogonadic hypogonadism. So your Turner's probably doesn't fit in the picture here already. She has a low TSH and T4, again indicative of central hypothyroidism. Her prolactin is on the low end, which could mean hypopituitarism as well. You frequently see low prolactin in patients with hypopituitarism. She has a low AM cortisol and her IGF-1 is low for her age. Her karyotype is XX, female. So in terms of diagnosis of growth hormone deficiency, this is just a screening test for IGF-1. It does not mean that she is growth hormone deficient. She would probably require further testing. However, certain guidelines do say that if you have 3 or more pituitary hormones that are deficient, you may choose to skip the growth hormone stimulation testing as well. Okay, this is again telling us that you need a minimum of 2 growth hormone stimulation tests using either insulin tolerance test, something which I showed you all earlier, a glucagon stimulation test, or another test called the arginine stimulation test or mesimoreline test. You all don't need to memorize all this, but it's just to tell you all that an IGF-1 or a growth hormone itself is not enough to tell us that the patient is growth hormone deficient. You may need further testing and evaluation. What are the further workup that we need to do for this patient? She had a bone age testing. Now, bone age is an indicator of the skeletal and biological maturity of an individual. This is very different from the actual age or the chronological age. which is calculated from the date of birth of an individual. It's usually done with the non-dominant or the left hand and wrist X-ray, and the radiologist has specific atlases to actually refer to and give you a bone age. And generally, we worry when there is a gap of more than 2 years in the bone age versus the chronological age. This patient's chronological age was 15 years, 2 months, but the bone age was of 10 years. Her pelvic ultrasound showed a small uterus, no visible endometrium, right ovary small, in the left ovary that was not visualized. Okay, so now, what are the tests that are further needed to refine the diagnosis? So as I told you earlier, we need to do an insulin tolerance test where we give insulin, we induce hypoglycemia, and then we look at the growth hormone cutoffs. We also have a GHRH plus arginine stimulation test, not very commonly done here. We commonly do the glucagon stimulation test in our setting, and the cutoffs are different for different areas. But generally, we use a cutoff of 3 mics for the glucagon stimulation and about 5 mics for the insulin tolerance test. Her MRI showed absent pituitary infundibulum and hypoplastic pituitary gland in the pituitary fossa. So her final diagnosis, yes, was growth hormone deficiency after further testing, and she has panhypopituitarism. Now, single growth hormone measurements are not helpful. So if you see a patient that has possible short stature and growth hormone deficiency, please do not send a growth hormone level. You could send off an IGF-1 level, but however, if your IGF-1 is normal, it doesn't exclude that she has or he has growth hormone deficiency. And IGF levels go based on age, that there are different cutoffs, and usually the lab will tell you what are the ranges for the particular age as well. Treatment of growth hormone deficiency is a little bit different in children compared to adults. The doses are different, and you adjust it within the range of 0.025 to 0.05 milligram per kilo per day. It's a daily subcutaneous injection, 7 days a week. And we monitor them every 3 to 6 monthly with IGF levels. We also look at the thyroid function test, their sugars, A1C before starting and during monitoring as well, because they have a risk, especially if they're obese and they have a risk for type 2 diabetes, because you can get insulin resistance as well. We also do bone age measurements monitoring as well during treatment. So now this patient was started on hydrocortisone and levothyroxine replacement, also on growth hormone recombinant therapy. And 1 month after that, the free T4 went up to the normal range, and the latest at the chronological age of 17 years, her bone age was at 12 years, attained a height of 144.8, which is acceptable for her mid-parental height. But the problem is, how about puberty induction? Now, this is not something that I'm going to cover in this talk, but just remember that as endocrinologists, we are often faced with, we need this patient, for example, she needs to attain puberty. At the same time, we want to maximize her height capacity as well. So we always need to discuss with the patient in terms of, in this kind of patient where it's already 15 years of age, then, you have issues where you don't have menses, your friends are looking at you and you're like, oh, haven't hit puberty yet, etc. So we need to time the growth hormone replacement and the estrogen replacement, because we don't want the epiphysis, the growth plates to fuse with initial high dose or introduction of estrogen too early. Again, in this patient, it was started few months into therapy. This is just a slide for your information in terms of induction of puberty, slightly digressing from the topic, but generally the principle is, if you're inducing puberty, we give small doses of testosterone or ethinyl estradiol, gradually increasing it over 3 monthly. And then for females, we add on progesterone later on when you have enough or adequate breast development and secondary sexual characteristics. Okay, so with that, I thank you. I hope everyone has benefited from this talk. Over to you, Prof. Laila now.
Right. Thank you, Dr. Tivia, for interesting talk and sharing of 4 cases. Shall we go to question? There are quite a number of questions here, Tivia. So the first one is, do we have CoPeptin in government hospital? Where is it available? Can we skip water deprivation test and measure CoPeptin? Tivia, you are muted.
Okay, we have it in the private hospital. We don't have it in the government hospital. Unfortunately, no.
Yeah, because Dr. Tivia now in private hospital. That's why she mentioned
Yes, I
CoPeptine.
have a
I
choice
will
of
never mention CoPeptine because it's also not available in UKM.
we have it available here, but again, if you're going to use it alone to diagnose cranial DI, it depends on your cutoffs and whether or not you will need stimulation tests with the CoPeptine as well. Okay, I agree with some of them actually say they use CoPeptine because it's less cumbersome than the water deprivation test. But again, it depends. If you have a patient clear cut, there's an MRI showing a mass there, you have all the other deficiencies, the patient is pouring, the sodium is high, you don't even need to do a water deprivation test. It's pretty much clear cut already.
Yeah, based on experience, right? And you can just try and give Minerin, see
Minerin
whether
and see.
it's actually work or not. That is actually, you know, how you diagnose in a way, shortcut,
Okay.
right? Then the next question is how long the interval we want if we want to start hydrocortisone and thyroxine together.
Actually, you can study it simultaneously. There's not much of an issue actually, as long as replacement is started.
Right. Although sometimes we do give
Sometimes
hydrocort first.
we give
yeah.
hydrocort first
Yeah.
and then you wait. But if the patient is in front of you in the hospital, you probably give the steroid and then after that start the levothyroxine the next day, you know, something like that.
Yeah. You don't have to wait for many days.
Too long, yes.
Yeah. Right. This again CoPeptine, so we skip that. If the patient on both hydrocort, or again the same question repeating, is there any risk of pituitary apoplexy in insulin tolerance test? What if insulin tolerance test is contraindicated?
Okay, there is a risk of pituitary apoplexy in the insulin tolerance test, and there are several other contraindications, especially if the mass is large. If you have a huge pituitary mass, yes, you may cause pituitary apoplexy, something that you need to be careful about. So again, you need to choose your patients when you're doing an insulin tolerance test. Alternative to it would still be your synectin test in that sense.
Right. Okay. It also depends, you know, which hormone you want to test. You know?
Yes, yeah.
Because with insulin, you can test your cortisol and also your growth hormone.
What hormone?
Yeah, but you can also rely on the other specific tests, like you can give CRH if you want to check for cortisol and also GnRH for the sex hormone. A bit tedious though. Okay.
And availability is limited also. If you want to get
Yes.
CRH,
Yeah.
not so easy. So yeah.
And you have to know how to interpret the results as well. It's not about performing the testing really,
Yeah.
but you know the results you have to be able to interpret correctly. How to manage women in reproductive age wish to have period other than referral to gynecologists?
Are we talking about patients with, I hope we're talking about patients with hypopituitarism.
Yeah,
It
let's
again
say
depends.
he meant hypopit.
In a hypopit patient, if you have an intact uterus, then you would give a combination of estrogen and progesterone in a cyclical pattern to induce menses. The story is different if you don't have a uterus or there are any other issues such as PCOS. You must make sure that thyroid hormone is properly replaced, all that. Of course, it'd be valuable to do a gynecological assessment as well, but if you know what you're dealing with and you're confident, you can start off with your progeniton, etc. for that kind of patient.
Yeah, so usually we tend not to work in silo, right? We also want to from our gynecologist to make sure that whether is the uterus there, you know, in the first place, as a cause of, you know, not having menses, right?
Yes.
So doesn't mean that when we refer to gynae, we don't know anything. So please work together for the sake of patient. Okay, right now. Next one is when growth hormone replacement need to be considered in an adult patient also. When is growth hormone replacement need to be considered in an adult patient with hypopituitarism? Do you give growth hormone replacement in all patients, Tivia?
We do give the patient can afford.
Yeah, because it's not necessary.
Yes.
Adult, you know, they're already growing. They cannot grow taller, but they will expand. But you tend to give for more for
metabolic for bone mass,
yeah,
you know,
yes,
muscle
for
mass,
bone,
energy,
yeah,
vitality,
abdominal
strength.
obesity, you know.
But it's expensive. It's not cheap, so it's not something that we usually give commonly in our practice.
Yes,
Cause
and
limit.
yeah, and the symptoms also overlap with hypopit, hypothyroidism. They feel tired, lethargy. Also, overlap with hypogonad. Like let's say they lack of testosterone, they may feel tired. More or less similar like growth hormone. So that's the least important, right, Divya?
Yep.
As compared to other hormones. Again, copeptine. Everybody's interested in copeptine. How much? Okay, how much, Divya? How much is it? The patient has to pay for copeptine.
900 here.
See, there, then you have to think whether, is it worth it that your hospital, especially government
Yeah.
hospital, like UKM also government, and KKM to have that kind of.
And then you take it, and then the sample lies, then another 900.
Yeah.
So not easy.
Yeah. Okay. How to manage the next question? How to manage patient with hypopituitary who plan to undergo TKR in a secondary care with no in-house endocrinologist? The patient
I'm assuming they're talking about the cortisol hormone
I
replacement.
think so. Yeah.
Yeah. Again, that's not the slides I've already shown as well, that when a patient is going for major surgery, generally what you can do is you can choose to switch it just a day before, or on induction, you give 100 milligrams that, continue 50 milligrams QID for a couple of days until patient is better, because we don't know. Some patients do very well after a TKR, some cannot eat, or any sort of complication happens. As soon as the patient is up and about, able to take orally, switch it back to oral, 20 TDS, and then taper it down back to their usual doses.
Right.
That's considered a major surgery, a major stress. So usually in that case, GA, because TKR is not a small op, you would give a induction dose, stress dose first, IV.
Yeah. If cataract operation, let's say they do under local and maybe daycare.
You could probably just give, if cataract op, local daycare, not much of issues, you can choose to either give a stat dose, 50 or 100, or patient can just double the dose instead, a couple of days before and into the day of op as well.
Okay, so please don't refer to endocrinologist just for just
Yes.
to do that. Yeah,
Yes,
and you
yes.
can continue the other replacement therapy, whatever the patient is on, like testosterone or thyroxine. Yep. Okay, and why we need minimum of 2 growth hormone stimulation tests to diagnose growth hormone deficiency?
Actually, that is based on our Malaysian CPG. However, in our Endocrine Society CPG, it doesn't mention that. But as long as I think if you can prove one test that is very clear, because it's very cumbersome, the test is not easy to perform. So asking a patient to come and do it twice, a GST and ITT, is not feasible. So I feel that if you just have one test and you can say safely that other hormones are involved, it is growth hormone deficiency. Again, you have a lot of problems, because if you don't achieve hypoglycemia sometimes, then you have an issue of interpreting the insulin tolerance test. Anyone who has done the test would know how difficult it is to put the patient there, induce hypoglycemia, take the bloods and get it done. So if you don't get a hypoglycemia or the patient doesn't have symptoms, then you may need to do a repeated test. So all this depends.
Yeah, most of the time they will have a bit of symptoms and you have a very high index of suspicion, then you perform. And you should sort of expect the results, what is going to be like, isn't it? Next one is, what is the ideal way to assess HPA axis recovery following pituitary surgery?
The answer I gave in my slide, it would still be an insulin tolerance test.
Yeah. Okay.
Unless,
how soon, Divya, you can perform that?
Usually we will wait. We won't do it in the first 6 weeks to 2 months. Generally, no. We'll wait for about 2 months to 3 months post surgery, and then talk to the patient and assess. Again, all this depends on whether the patient was on replacement prior to the surgery, or you only gave it during op because it was a large tumor. All this depends as well. Is it still a remnant? Is it still very large over there? So it goes clinically as well, but not straight away after surgery, not in the first 6 weeks after op.
Yeah, because it's still edematous, you see. So no point assessing when the patient is not very stable. Next one is, I think this is the last question here. How to titrate minerin in patients with DI with high requirement of minerin? Example, persistent polyuria despite on minerin 3 to 4 times a day. Have you come across this, Divya?
What I notice is a lot of patients, they drink a lot of water as well. So if you don't educate them about how much to drink, that is one issue. Number two, the timing of the minerin may not be in accordance to the time that they start to pour. So you would probably give a regime of 8 o'clock or 10 o'clock or BD dose. Sometimes they go back with BD dose, but BD can be any time. So you need to be very specific as to when they're exactly pouring and titrate it in such a way that at that point in time, a couple of hours prior to that, they're given it so that it doesn't disturb them. So you rarely see patients that are on minerin that are not well controlled if they are able to modulate their oral intake in terms of fluids.
Yes, I totally agree with you, Divya. You know, very rarely that they require 4 times a day. At the most, maybe about twice or maybe 3 times, depends. And you know, if you talk about still pouring out 3 to 4, still pouring out a lot of water or a lot of urine, meaning they've been drinking a lot, isn't it? More like psychogenic. But usually they will respond. You tend to give a lot of doses of minerin, then you worry about water intoxication. That's even more dangerous.
Yeah. And usually we give it maximum 3 times because the duration it can act for about 8 hours plus. So you would rarely see 4 times a day minerin.
Right. I think that's the question. There are all the questions now. Okay. Right. Is there any role for prolactin measurement in case of panhypopituitary?
Okay. In the case of panhypopituitarism, if all the other hormones are low, you could very well do a prolactin level because you don't know if you're dealing with a prolactinoma to begin with in the first instance. But generally, if you have a hypopituitarism, your prolactin levels will be low.
Yeah. Simple rule.
Yeah.
Okay. That's all the question for now. I want to allow in the 1 or 2 minutes if there, in case there's any more question.
Someone asked here, once secondary hypothyroidism is diagnosed, is there any role for measurement of TSH or is free T4 alone adequate? This is a very good question because we always send off TSH and T4 together. If the patient is well replaced and the T4 is in the mid or upper limit of normal and the patient has been on that dose for a long time, I don't see a need for repeating TSH unnecessarily.
Because it's already central, isn't it?
Yeah.
Right now, my question now, Divya, how often you do all these dynamic tests in a private setting?
Quite often.
Right.
We use the daycare to do it.
Uh-huh.
Most of the insurance approve the daycare for the dynamic testing. So synectin tests, ITT are all done in the daycare.
Okay, so the insurance will cover, is it?
Yes, they cover.
Oh,
they do
right,
cover
that's
this.
good. Okay, any more? Any further question? Any more question? No. Okay, I think we've answered all the question. A lot of questions are actually on CoPeptin. I've enjoyed listening to your cases, Divya. Really interesting, right? And a bit on tamoxifen, the case that you shared, the first case. You know, the diabetes insipidus, is it related to the tamoxifen or she has, you know, another pathology like hypophysitis?
We actually at that point in time, it was actually a bit of a dilemma because we didn't expect to see a possible metastasis at that place because there were no other lesions as well. And this patient also didn't come for follow-up properly. So even the tamoxifen, she kind of missed the appointment in between. So we don't know if she has been taking the tamoxifen properly or not. History also was not very good. And she was only seen by the oncologist, which was many months ago. So it's a bit difficult to say whether it could have been a hypophysitis or not. But there was a stalk thickening and there was a nodule as well. When we offered her for biopsy, again, the neurosurgeon said no, which is fair. And they assumed it was metastasis at that point in time. And they proceeded with stereotactic radiation instead.
Right, but it's not very common, isn't it?
Yeah. But I think this is the second or third case that I've seen with breast cancer with pituitary metastasis.
Yeah, And different the different histology of breast cancer, they tend to match to the
Differently, yeah, correct.
Yeah. Right. Okay. Any further question? No. So I think we have had a very interesting discussion, interesting cases. So with that, let us share. Let us thank Dr. Tivia for her talk and discussion today and the case sharing. Back to you, Eugene. Thank you, Tivia.
Thanks,
you.
Prof. Laila. Thank you, Dr. Tivia, for the very eye-opening and enlightening session. I think it really benefited all of us, especially those of us in secondary care and also primary care as well. So with that, we'll end the session for today, this evening. Stay tuned for next week for yet another session as well. So thanks and good evening again, everyone.